Hello and welcome back to Bedside Murmurs, a podcast where we chat with doctors about their careers, pathways in medicine, clinical tips and much more. If you have any questions or have any ideas for guests that you would like to see on the show, you can send us an email at podcast@medsoc.org.au or you can direct message us on Instagram at Bedside Murmurs. I'm Emily.
And I'm Sean, and we will be your hosts. Today we have the pleasure of speaking with Dr. Shannon Nott, who is a Royal Flying Doctor Service Southeast Section's Chief Medical Officer and Health and Clinical Service Executive General Manager. Having grown up in rural New South Wales, just outside of Dunedoo, he has a close connection to healthcare in the bush. Dr. Shannon has over a decade of experience as a rural generalist, including 6 years as a Rural Health Director for the Western New South Wales Local Health District, while also working part-time for the Royal Flying Doctors Retrieval and Primary Care Services. He is an Adjunct Associate Professor at Charles Sturt and the University of Sydney, and is passionate about supporting the next generation of healthcare professionals. Welcome, Dr. Nott.
Thank you. Thanks for having me.
So you've had a very illustrious and varied medical career, but let's start at the beginning. Where did you go to medical school and what was that like?
So I actually went to UNSW here. So I, as you per the intro, I country boy and went to boarding school in Sydney and went and got into UNSW medicine, and is I suppose what a lot of people would think med school's like. A lot of learning, great ability to make friends, and I was probably a little bit too social in the early years. Played a lot of sports and really enjoyed university. And I think it wouldn't have been too much different to what you guys experience these days. Only the campus now is much, much prettier and has a lot better food than when I was here.
That's the improvement?
Oh, it is. Yeah,
really?
Yeah,
okay.
Yeah. Well, and better facilities. When I was here, the buildings were still very 60s, 70s-ish, and some of the Wallace Worth buildings were just starting to go through some of their early phases of renovation.
Oh, so you would have been here way before any of like the new upper stories were built, right?
Oh yeah, so it was the old original buildings. So the Lowy Research Wing that's on the side there, that was the first building that was built. So that was built while I was at UNSW, and where Wallace Worth is, which used to be predominantly where the med school did a lot of its teaching, was very much some of the original buildings.
Oh wow, yeah. A little bit of history, I think the way we run it now is everything above what we have as our first two floors. All the research floors above is completely new. Before it used to just be like a shed or something like that, right?
Yeah, it was a very old brick building that probably resembled sort of housing commission or something like that. So yeah, it was pretty old and pretty dingy.
Did you find when you were studying medicine in Sydney that the course covered what it was like to do rural medicine, or did you find that it was pretty centred on metropolitan healthcare?
Yeah, so I think one of the strengths of UNSW, and I think it's continued, was the public health unit that it has here. And so I think through that there was a good idea around social determinants and that there are inequities that exist across the entire health system, particularly rural and remote, First Nations healthcare, refugee health, and obviously Asia Pacific and developing nations. I think if I think back to some of my very early lectures, there's a particular lecture that was had by a researcher, and I can't recall who this person was, but they put up a slide that said living and working in the country, especially in the most remote parts of Australia, is a health hazard. And in going through that slide or that lecture, it was pretty clear to me that this person probably never had worked beyond the Blue Mountains. And they were obviously talking about statistics and that side of things. And I think what was being painted inadvertently was a very bleak picture of rural and remote healthcare. And yes, there are significant disparities, but that sort of quote itself really has stuck with me, and that what I've just said is pretty much verbatim what's on the slide, because how can it be in a rich nation like ours, that arguably has one of the best healthcare systems in the globe, have significant disparities just based on where people live. Why? Because somebody decides to live in a rural or remote community that they're more likely to end up in hospital or die prematurely, or have diabetes or heart attacks, strokes. And so for me, it was a wake-up call around that there are significant areas for the Australian healthcare system to improve. But two, also, it was an obvious part of the curriculum where I felt that we were painting a picture of all of the challenges and problems, but not why would you go live there and work there. And so that sort of started me on a bit of my rural healthcare journey, really.
Yeah. We had on just a few days ago, Dr. Sonia Henry, who was talking about the exact same kind of disparity and how in rural areas, there's a lot of diseases and there's a lot of health conditions that just shouldn't really exist in a first world country at all. And also based on how well our healthcare system is in the metropolitan area, it is frankly quite disgusting how bad the healthcare is as you move further and further remote.
Yeah, so I think generally the further you get from capital cities, the harder healthcare access is, and when you look at a lot of markers around health outcomes, generally it gets worse. And obviously there are parts of the city where people have significant barriers in terms of accessing care and similar poor outcomes, but more from a universal and a population basis. There are significant challenges in rural and remote, and there are differences between regional, rural and remote. We kind of tend to lump them all in together. But in saying that, whilst those challenges exist, there are great opportunities for people, particularly within the health sector, to be able to make a massive difference and also get a really good experience both professionally and socially.
And did you have any experiences outside of metropolitan Sydney in medical school?
Yeah, so while at UNSW, I was heavily involved with RAHMS, which is the Medical Society.
It's great to see that.
It's still continuing.
Yeah. Well, it's still running. I think they've got a different logo than when I was around, but I was heavily involved with them. I was heavily involved with the National Rural Health Students Network, which I know still exists as well, and took up a lot of opportunities at university. And I think it was some of those early opportunities that I had through either MedSoc or RAHMS or at a national level with the NRHSN that allowed me to sort of find my space in terms of rural and remote healthcare. And so we were really lucky as I was going through university. There was a fair bit of money put into trying to promote rural and remote healthcare and allow medical students to see the opportunities there. So we did have big national conferences and rural health conferences where universities from across Australia were able to get together for national rural health student conferences. So I went and ran a number of those while I was at university. There was a lot of sort of collaboration between universities around joint events, and I think one of the events that RAHMS still runs today is RAW, their Rural Appreciation Weekend.
They do.
So I set that up on my family farm originally.
Oh,
so
wow.
I ran that for seven years.
Wow.
So you initiated that?
Yeah, so
Cool.
it was a program that we set up, and we would cap our numbers around 180 students every year, and it was very much a big camping, and so we'd run 3 or 4 days of camping out on my family property out at Dunedoo, where students from all predominantly New South Wales rural health clubs, but we did have people from South Australia, Western Australia, Victorian, Queenslanders come down as well, and go camping, see what it's like to live and work in rural settings, hear from really inspiring speakers, but also do workshops as well out in the middle of the bush. So it was pretty cool.
Oh, that is really awesome. I think it's really important for medical students to have that experience of actually going out to rural areas, just mostly even just going out of the city, having that experience. I know I went to a Port Macquarie trip run by RAHMS as well, and going there, maybe not the most remote, but also just having the experience of going to a place where I wasn't very familiar with really opens my eyes to like how healthcare can be very, very different.
Yeah, and I think so. I went to rural clinical school. I was at Albury, so I did part of my training down there, and I think the rural clinical school is a great way of being able to experience it in a setting, particularly if you haven't done much rural and remote stuff or predominantly have grown up or lived in a metropolitan area. The clinical schools are a great way of being able to get that experience without throwing you in the deep end too much. And so obviously I think Port's got end-to-end training there now, and you can do more and more in those sites, and you've got a cohort of peers that you're with. It's not like you're sort of sent somewhere by yourself. And so all those experiences are really great. The other thing for me was I got to do bit of rural and remote medicine through my elective. I went up to Katherine in the Northern Territory and loved it up there. I've worked there since as a doctor, and I've still got some very good friends that work there today. And so, there's plenty of opportunities. And for me, it was about, one, looking at my interest areas, but also being able to take up those opportunities gave me a huge amount as a medical student, because the teaching was fantastic as well. There's less sort of layers and hierarchy within particularly those regional hospitals at your rural clinical schools that allow you to get hands-on experience. The tutors and educators and doctors are generally really invested at a local level, because everybody sort of knows each other, whereas at some of the bigger places you can be a little bit anonymous.
And once you had graduated from medical school, where did you work as a junior doctor?
Yeah, so I got my internship at Orange, so Orange Health Service, just on the other side of the Blue Mountains, and I loved it there. So I knew when I originally went there, it's not like I went with a big group of friends from UNSW. I went there because I heard it was a great place to do your internship, and it was very popular back then, and some of the relationships that I've formed with colleagues, particularly that intern group that we're with, are some of my best friends today from a medical background perspective, and we still catch up years and years later, and still a number of us still work together in different settings, or have come in touch with each other, and a lot of us have ended up sort of, as we've gotten older, married and that type of thing, going to each other's weddings, and so that for me was an awesome experience. And after doing sort of internship residency there, and I started doing some early sort of registrar years at Orange Hospital as well, I then transitioned and got a Churchill Fellowship. So it was at a point of time where the government, through elections, was talking about high-speed broadband. It's probably giving people an idea of how old I am.
Oh, wow.
So they were looking at high-speed broadband, and they were talking about how high-speed internet will revolutionise healthcare in amongst a whole host of other areas. But at that point in time, there was no detail around, well, how does faster internet equate to better healthcare? Yeah. So these days, particularly post-COVID, the concept of digital health and digitalisation in healthcare is pretty much the norm. But at that point of time, which is essentially about 10 years ago, it's not that long ago, we were talking about high-speed broadband revolutionising healthcare, particularly for rural and remote areas, but there was no plans. And so that's where, with my Churchill Fellowship, I wanted to go look at rural and remote locations across the globe and how technology, particularly, and digitisation and virtual care or telehealth was supporting healthcare in remote communities. And so that was another transformative experience for me, because I got to travel through very remote parts of Canada, right up to the Arctic shelf, into very remote First Nations communities and lakes districts throughout Canada. Went through Alaska, where 75% of Alaskan communities are not accessible by road, so flew into a lot of very remote locations that don't have access to medical care as we would know it, even in our remote areas, and that were utilising telehealth carts from the early 2000s as their main tool that they were utilising in terms of ECGs, video, even digital stethoscopes, things that are sort of still relatively novel. This was sort of normal business as usual in some of these communities, and then went down to Brazil and went to some Amazonian communities and looked at the way in which they were utilising technology to provide a sort of population and public health response. Because at that time in Brazil, it was illegal to provide any care direct to patients via a technological means because of the risk of people fraudulently pretending to be doctors and that side of things.
Yeah, that would be.
So that was fantastic. And then following that, I returned to Western New South Wales.
Wow.
As you were saying, all your experiences, it kind of like opened my eyes really to where medicine and healthcare, if you're passionate about something, can take you. And to all these different places, how it can like really be a massive help to the communities that you're interacting with.
Yeah, absolutely. And I think one of the things that I've been fortunate enough through my career is that whilst I've sought out opportunity, when you sort of seek it out, it also tends to come to you a little bit. And so I think that particularly that Churchill Fellowship, I spent a lot longer than I think these days they sort of say you spend like 4 to 6 weeks. I ended up spending the most part of sort of half a year or so overseas doing this research. And it wasn't just remote places I went to some larger hospitals as well, like Sick Kids in Toronto, which is arguably one of the top 1, 2, if not top 3 paediatric hospitals in the globe, looking at different ways of doing things. It was also at a time where Google was looking at Google Glass, where you sort of...
Oh, that is, that's such a
early
milestone
days.
moment.
Yeah, it's obviously not there anymore. But but there was still, there was a lot of biotechnical organisations looking at how do we advance and push boundaries of technology in the healthcare space to be able to one, improve quality outcomes for patients, but also how do we sort of create an ability to cross the gaps that exist in the system. And so absolutely, I think from that, it really doing that Churchill Fellowship has led me to some of the medical leadership work that I've found myself in recent years. So directly from that, a couple of years later, I found myself working out in Western New South Wales, looking at the way in which we can revolutionise our telehealth services. So particularly for communities that were having challenges with rural and remote workforce, how do we provide support? And very much I mean support. It's not... Technology should never be seen as sort of a replacement for people, but there are ways that we can support and supplement the healthcare system. And so virtual care was a space that I lent into in sort of after that Churchill Fellowship period, where I was fortunate enough to work with the district around creating a unit called vCare now, which was essentially a 24/7 virtual support and critical care advice unit. That unit ended up winning Premier's Awards for sort of supporting the public system, and then have gone on to get a number of research programs together where we've created the first sort of in-hospital virtual clinical pharmacy service for small rural and remote hospitals in recent years, and more recently set up a virtual rural generalist service where you've got rural doctors working to an advanced skill to be able to support the community where there's either no local doctor or where local doctors need additional support because they can't work 24/7. And that service also ended up a couple of years ago getting a Premier's Award in terms of looking at how digitisation was able to support public services, particularly public health systems.
I'm interested to hear, based on your experience in this sector, what you think the biggest bottleneck is currently in providing healthcare through either telehealth or through virtual platforms.
Yeah, look, I think there's a couple of things. One, obviously through COVID, the whole healthcare sector had to embrace this space, particularly the way that most mature healthcare systems across the globe were having to function. And so that in many ways pushed us along a fair bit. But the other aspect was that while we were pushing down this line of telehealth, virtual care, increasing digitisation, a number of the models weren't fully evaluated and the evidence base wasn't there. And so one of the big things that through my career and through the opportunities that I've had is being able to not just implement but also look at robust evaluation and recognise that no matter what model of care you're providing, whether it's face-to-face care in a remote community, a large tertiary hospital, or via some form of technology, there's always an ability to improve. And the way that we improve is through quality improvement mechanisms, ability to understand where do we need to pick up. And particularly for some newer models, it's important to think about evaluation in the early phases. And so I think some of the hesitancy around this space is one, not having a solid evidence base around, well, what's good, bad, when should we use it, when should we not, what do patients need to know, what particular symptoms should we say, look, you can't actually do any telehealth here. And even the concept around, is there value between video versus just audio only? Because if you think about telehealth, we've been providing phone advice since the invention of the telephone. RFDS, the organisation I work for now, so in the early 1920s, when RFDS was first set up, one of the big barriers to being able to provide medical and emergency support into remote communities is that you can't provide emergency support if you don't know there's an emergency. And so a lot of these remote communities in the 1920s weren't actually on the old telegraph lines. So it was for you to be able to call for help, you'd have to often in those days, particularly ride a horse
run a line,
and run to somewhere where there was a telegraph line, and then what people would do would Morse code to RFDS. And so John Flynn, who founded RFDS, he worked with a gentleman called Alfred Traeger, who is much less known but equally as important as John Flynn, because Alfred Traeger actually invented the pedal radio. So essentially developed this device that was a generator, so you pedaled, and it allowed you to send radio frequency communication. So the early version of it was Morse code, and then it went into what we would think is more around audio a little bit later on. But that was a version of telehealth as well. It wasn't just calling for help and say, fly the plane here. It was also going, oh, so-and-so's broken their leg. What do we do here? And they'll being provided with that advice. And so I think it's the evidence base that has been a challenge. Funding models around this space as well. And I think outside of the virtual care environment, one of the biggest challenges to delivery of, I suppose, equitable healthcare is the levers that we put in place in the healthcare system. So if you look at any evidence basis around how do we provide universal healthcare, and essentially what you're talking about is how do we provide universal health care when there are so many variations and disparities that exist across the society? Most of those models developed by a World Health Organization or any sort of modelling agency shows that you need to have an ability in funding models to be able to provide equitable funds and resources into a community. So when I look at from an RFDS perspective, a remote community up in the corner or up around Cameron's Corner, which is between sort of Queensland, New South Wales, South Australia, delivering care to a remote station owner up there is very different to what I would just down the street here in Kensington. We have to fly people in very expensive planes that cost a lot of money to fly into very remote parts of the country and be able to establish some form of infrastructure to be able to provide care there without sort of the throughput that you would have here in Kensington. So clearly that type of care on a if you were looking at purely from a financial perspective, it's going to cost a lot more per head. But that's an equity lens that you apply in healthcare, is recognising that those people who need the care the most or who are the most vulnerable need to have funding mechanisms that recognise the need, recognise vulnerability, and in this sort of circumstance also recognise that geography plays a role around access, and have mechanisms that allow for services to get in there.
So it sounds like you've had a lot of experiences working rurally, both as a junior doctor and then continued out through your career. What did you do your specialty training in?
So I'm a rural generalist. So I'm a fellow with the College of Rural and Remote Medicine. And so clinically, I am a specialist primary care physician, but I also have done a lot of work. So I've also got qualifications in anaesthetics. So I do anaesthetics 1 week a month. And I've worked a lot in rural and remote emergency departments. And obviously prior to being in this chief medical officer and executive role with RFDS, I did a lot of retrieval medicine as well. So the great thing about my work and sort of the specialty area is that I've been really able to tailor sort of the areas of interest clinically for me to be able to maintain a scope of practice that keeps me, I think, one, fresh, and also allows me to meet the needs of the communities which I serve. And so, I've loved being a rural generalist, and it's really exciting at the moment because likely in the next 12 or so months, rural generalism will be recognised nationally as a subspecialty within its own right. And
as it should be, yeah.
Yeah, so that's my base sort of specialty area. I'm also, given that I've been in a few medical leadership roles as well, working toward my fellowship with the Royal Australasian College of Medical Administrators as well. So hope, fingers crossed, that'll get done in the next year or so.
I really liked what you said at the very, very start there, where you said that you've kind of slowly developed a skill set that makes you best fit to manage the health disparities and the problems within your community. I really like that lens of like, I'm becoming a doctor and I'm trying to learn all the things required so that I can be of most service to the community that I was born and raised within.
Yeah, it for me, and also I suppose it suits my own sort of interest areas. And one of the challenges I had as a junior doctor was just going, well, what
motivates me?
What area of medicine should I go into? And I think I liked cardiology and I liked internal medicine. I liked emergency medicine. I liked the concept of working in remote primary care and remote medicine, and I had a lot of good mentors across multiple places, and was quite torn, particularly in the early years. And I think that Churchill Fellowship experience that I mentioned to you before was one of the spaces where I was able to sit back and go, actually, I want to do rural generalism. I want to get my fellowship with the College of Rural and Remote Medicine, because I'd met so many fantastic people from across the globe who are working with a broad skill set, doing exciting things in really remote locations, and that sort of, I think, clarified things for me. And I think the other thing for the med students, we give ourselves a lot, particularly junior doctors, have this sort of, whether it's a profession thing or whether it's innately one of the characteristics of junior doctors, that we have to get on a program and get on that program and you have to finish it even if you don't like it, and there's all this pressure, and you're like, I've met so many junior doctors that sort of find themselves halfway through a program and go, this is actually not for me. I've seen a number of them continue and not really enjoy their profession, and others tie themselves in knots about, am I a failure because I don't want to continue with this? And I think message for junior doctors is okay to not know fully what career path you want to go down, and it's also okay to change things or take some time to do something that you really enjoy to be able to provide you with that clarity. And then the other thing I think that, just when I look back on those early days in medicine, was having people around you that can be sort of honest and not I suppose as biased as little, because naturally if you're an emergency physician and you've got young doctors you're working with, you're going to naturally try and say, look, emergency medicine's pretty good, or cardiology's pretty good, or rural generalism's pretty good. But if you can find those people that you know will provide good advice for you as a person, you as a young doctor, then that's a good thing. Yeah.
We were chatting last episode again with Dr. Sonia Henry, and she was speaking about her experiences going into general practice, and she had very similar reflections to you about that pressure on junior doctors to go into training programs that they may not actually want to do. How is rural generalism, though, different to general practice?
I think so that there's a formal definition, if I sort of get a bit nerdy on it. There was where a lot of this was wed out of was the concept of that there were rural doctors doing this broad scope of practice, and the concept of rural generalism was, I suppose, defined through this statement called the Collingrove statement, where essentially it talks about a rural generalist being someone who is a specialist in primary care. So a rural or otherwise doctor that is a specialist in primary care, so essentially a general practitioner, but with advanced skills to be able to support the emergency and sort of hospital-based needs, as well as any other specific needs to meet that community, overall community profile or community need. And so the two are very close, but I suppose a rural generalist has formal training beyond the specialty of primary care to be able to step into the hospital environment as needed, or other advanced skills that support their specific community. And that may be things like dermatology, it may be mental health, it may be somebody that's non-procedural that focuses on women's health as well. So everyone sort of naturally gravitates when you talk about rural generalism to the procedural sort of advanced skills, so like mines, anaesthetics, or obstetrics where you can do Caesars, or surgery where you do colonoscopies. But the reality is that it's not just about having a procedural skill set. It's about that sort of community need and being able to support some of the acute care needs also of the town or community you live in.
That's really interesting.
That's super profound. It's super interesting that I think rural generalism has. I think it's because it feels as though it's a subsidiary of primary health. A lot of people think it's just like, a GP that lives in a rural area. But it sounds like it's so much more than that. It entails essentially being the person that can provide the healthcare of basically a metropolitan hospital with all the limitations surrounding rural healthcare, that being access, that being funding, that being all the areas of rural healthcare that we don't really even think about in a metropolitan hospital, like access to like equipment and imaging.
Yeah, so I think there's a lot of, like with RFDS at the moment, we bring doctors on, both rural generalists, people who are GP specialists in terms of primary care, or emergency critical care specialists as well. And so the biggest challenge in the RFDS space, where we are working in some of those more rural, more remote, more resource poor areas, is that there is a clinical aspect to it, but the harder part is actually understanding the logistics. Think about patient disposition. Just because I can treat someone in a location, is it actually in the best interest for that patient to stay there? Because for us, particularly as doctors, we do interventions, but then we tend to leave a hospital or go somewhere else, and the nursing staff are there, and it's more around the capability of the places that people are in, as opposed to necessarily the skill set of one individual. Because when you think about patient safety, it's much broader than what can a doctor do. It's the whole system, and we set up systems within healthcare to support patient care, because it's a little bit like that Swiss cheese model. If you don't have good safety netting across multiple areas, then it's likely that people fall through gaps, and that's where adverse patient outcomes happen. In saying all that as well, though, I don't want to diminish the important role that good, strong primary care physicians, GPs provide, because that essentially we know that there's multiple studies globally that with adequate and appropriate primary care, that is the best bang for buck in terms of actually healthcare services. If we provide robust primary care, we keep people well in community, we avoid deteriorations, avoid the need for acute care services or minimise that need. And effectively that is a space that we need to focus more on. You talked about sort of what are some of the barriers in that space. We need more very good primary care specialists in Australia, and we need to recognise that is an absolute crucial role. And I think even when you were talking about rural generalism, the core of rural generalism is doing primary care really, really well, because without that, you're essentially focusing on an acute care model, which we know is not in the best interests from a longitudinal sort of healthcare model or a wellness or well-being model within health. Yeah.
You've been speaking a lot about your involvement with the Royal Flying Doctor Service. How did you first become involved with them?
So I talked to you before about I was developing after my Churchill Fellowship, a couple of years after I was developing a lot of these virtual care programs. At the same time, I was still trying to finalise my training and that side of things. And so for me, it was a good combination of me being able to look at ways I can make an impact in the healthcare system more broadly, so through some of the virtual care work and medical administration or medical leadership roles, but also maintain clinical medicine. And so the way that I maintained my clinical medicine in those earlier years after I came back from overseas and worked a little bit up the top end and other places was by working with RFDS. And so it was a great opportunity for me because I'd done a fair bit by this stage of my career, done a fair bit of an emergency space. I had completed my anaesthetic advanced skill within my sort of fellowship training pathway. And it allowed me to combine my critical care skills, so I was doing retrieval medicine, with my primary care work and finish off my primary care training. And so for me particularly, some of the most valuable experiences that I have had has been in remote medicine. I love remote medicine. I love working with rural and remote communities, love travelling. And so the ability for me to work with RFDS allowed me to combine these sort of two clinical loves, I suppose, in terms of critical care, which I did part of the time, but also primary care and continuing to advance myself as an individual from that primary care or remote medicine side of things in an organisation that was very well supported, well established, well known in communities, and ultimately also that sense of satisfaction that I think a lot of people get from working in primary care. It was fantastic for me as a young sort of trainee or registrar with ACRM, because you can clearly see that there's so much need, there's so much community embraced by RFDS, and so much good work to do that it was sort of a win-win all around for me.
Yeah. What does it take, this is a question mostly of ignorance, to become an RFDS?
Yeah, so I think if you think about it from a purely doctor input, there's a spectrum of doctors that you want. Most people that have watched whether it's the TV show or have heard of RFDS, immediately their brain goes to emergencies and flying in planes and picking up people off the side of the road or in a remote community or something like that. And so, yes, that we have those doctors and we have need for those doctors, and what we advertise for people to join our retrieval service, that they have to be at sort of that advanced trainee level within, at least advanced trainee level of one of the critical care specialties, so either College of Emergency Medicine, intensive care or anaesthetics, or you need to be sort of pretty much done your advanced skill in anaesthetics from a rural generalist perspective, and sort of at that advanced trainee sort of level, so toward the back end of your rural generalist training. So that's sort of the emergency critical care space. We also provide a significant amount of primary care services, rural and remote primary care, and that is a spectrum from delivering running general practices in the way that you'd expect sort of a bigger town, or even just a contemporary general practice that most people would have come in contact with. We have those services, and so we have absolute need for those people who go, look, the remote stuff's a bit scary, or it's not really of interest, or the hospital stuff's really not of interest, but I'm a damn good primary care doctor. So we'd absolutely need those people, and they are a crucial part of our organisation, will continue to be. And so I think sometimes this thought of having to be this superhero doctor that does everything can scare people away from RFDS, but absolutely not. We like, the reality is that GPs are superheroes. It's just that sort of you can't necessarily have a dramatised TV show, although there have been. But we absolutely have need for GP specialists who do very high quality primary care, and that can be in larger regional towns. We have remote medicine as well, where again it's primary care, where they've got ability to work within their primary care specialty, but are doing remote medicine stuff. So there is still the possibility of someone coming in really sick, there's no local hospital, and you're having to try and work with supports of your emergency colleagues around how do we manage this person in a community, get them out. And we're increasing our ability to also look at people with advanced skills that are non-procedural. So, for instance, mental health. So we across New South Wales, across Australia, we have RGs training with mental health advanced skills. So we're looking at integrating RGs with mental health sort of subspecialty areas or interest areas within our mental health team, our drug and alcohol teams. And I'm hoping that we'll expand that to areas like paediatrics. And just this year, I've worked with the College of Rural and Remote Medicine to accredit RFDS as a training site for remote medicine as its own advanced skill. And so we're looking forward to bringing on registrars as well. Yeah.
When would the Royal Flying Doctor Service be called for help in a typical scenario, or is there no such thing as a typical scenario?
Well, I think, there's probably no such thing as a typical scenario, but generally speaking, from an emergency sense, we're brought in when a patient is in a situation where their care needs exceed the ability to keep someone locally.
Yep.
That may be a local hospital that has somebody that's septic that needs to be in intensive care, but there's no intensive care unit, and so we'll go there and pick them up, stabilise patients, move them to definitive care. It may be that someone has come off a motorbike on a very remote station, they've called the RFDS emergency line, and they're in the middle of nowhere, and we've got this really logistic challenge of working out where this person is, where's the closest airstrip that we can land on, how do we get there and backwards, there's no ambulances in these places. So the work that we deal with in an emergency sense is varied, and that's part of the appeal of the job. And then the other thing is that we provide virtual care or telehealth into a lot of particularly far western hospitals so that nurses who are essentially running these places have someone that they can call on and get support from if needed. It's not always about moving a patient.
Yeah. So how has working with the Royal Flying Doctor Service been different to the other jobs that you've been doing in medicine?
I think RFDS is I think when you go out to remote communities or rural communities, RFDS is this sort of iconic organisation that I'm not sure everybody in a metropolitan sense would always appreciate, but you go out to any rural or outback community and people have heard of RFDS. It's sort of almost built within sort of that Australian identity, particularly in rural and remote areas. And so I think there is a lot of pride and certainly working with our clinicians, not just doctors, but our dentists, our mental health clinicians, the people that support, so even our administrative staff, our engineers, our pilots, all those people are incredibly proud of the work they do. And I think one of the great strengths of the organisation was that it was born out of rural and remote Australia. Us in southeastern section or the New South Wales part of RFDS, our original base was in Broken Hill. We still have the base there today, and nearly the entirety of our healthcare operations are out of Broken Hill or Dubbo base, all smaller sites in between those. And so the identity of RFDS is very much this rural, remote first organisation where the people that are delivering that care are very much wedded to and see themselves as part of that sort of RFDS identity, and that concept of sort of the furthest corner, the finest care is something that is innately intertwined with the way that people see themselves and what drives people. And I think that is what is the biggest difference with RFDS compared to any other rural health organisation, is that it's not just a tagline, it's very much embedded within culture, particularly of our healthcare workers, that sort of we are here to help and that deep commitment to making a difference for rural and remote is pretty much interwoven within everyone's DNA.
What have been some of the highlights for you personally working for the Royal Flying Doctor Service?
Look, there's so many highlights. I think if I look at a couple, I think there is a real beauty of being able to fly across the desert with the sun either rising or setting and looking down on the desert, and you see these beautiful different colours of sand, reds and whites and everything in between. And whilst you're potentially going to an emergency, there is a real beauty and peacefulness of there's something about the desert that is incredibly beautiful. And every time I get to fly, particularly clinically, you do get that sense of that this work is important and needed. And so that to me is an incredible, I suppose, privilege that we get with RFDS. The other one I think that I'll share is that I remember going into a community that we just set up our one of our new primary care services. So this is a really remote community, middle of the bush, and I remember going there and it was the first time we were running a clinic, and this wife and husband couple come in, and like a lot of rural guys out in this part of the world, they're sort of always forced by their wife to come in to get help. And this guy, his problem was that he said, oh, look, every time I sort of bend over, I get this weird cough and it sort of feels like something's stuck in my throat. And after a bit of chatting with him, it was also like his face would go red when he was putting his arms in certain postures and that type of thing. And I examined him and he had a really large thyroid mass. And to the point where eventually, after with a lot more trying to tease information out of him, I essentially felt that he had a very large thyroid tumour that was impinging both on his airway and his esophagus. And so we actually brought this person back on the plane with us that day, and I got scanned at a larger community with a CT scan, and it did find that there was a large circumferential thyroid mass that was partially occluding his airway as well as impacting his ability to swallow. And we got him out to Sydney later that day, and he ended up having surgery on it the following day at a large tertiary hospital. And when they were doing all the workup for the surgery, found that he had a thoracic aortic aneurysm as well. So he ended up getting his thyroid mass addressed and them fixing the thoracic aortic aneurysm within essentially 36-hour, 48-hour window of me seeing this person in a very remote part of the country. And I think that to me is a nice story in terms of, one, the value of good primary care, but also pointing out that without access, that person was holding off this. That had been having symptoms for a long period of time. Was just getting to a doctor was so difficult, and it was just a cough. It's just a cough, doctor. Without realising the seriousness of this. And so I think it's a nice story because we do focus a lot on the emergency things, but that one particularly rings out to me because of without that, I don't know how long that guy would have held off. Probably to the point where he couldn't swallow, to be honest, or couldn't breathe.
Or the thoracic aortic aneurysm.
Or that could have burst and he was not around.
And with that, and with all the beautiful views of Australia, how would you encourage medical students who might be interested in the Royal Flying Doctor Service?
I think there's a number of ways. We offer electives. I've had a number of students on elective with us. The other thing for us as well, I think when you get out to your junior doctor years, seeking out opportunities. So even for us, there's a program called the John Flynn Pre-Vocational Doctor Program where you can do sort of GP terms during your PGY1, PGY2 years. And so RFDS have those in partnership with Western New South Wales Local Health District and Far West Local Health District. And obviously GP training, we train people in RG training, we train people within critical care training. So there are multiple ways, and I think just reaching out to us, we're always keen to have people work with us that are truly interested in this space and sort of ultimately, like what I said before, that sort of from a value basis, they're really keen to make a difference.
Do you have any final comments to medical students about why they should consider going rural or remote?
Yeah, I've looked so many, but ultimately I think I have had a very fortunate career to date, and I think sometimes either through design or ignorance or just some people being blasé, there's this assumption that you go rural and it's sort of this dead end space. I have found completely the opposite. I've travelled the world, continue to travel the world, have opportunities. I've done work with World Health Organization, other organizations, because I've chosen to be rural and not in spite of it. And I think some people think, that's sort of the anomaly. The reality is that all the people that I know that truly go rural remote, embrace it, are some of the most inspirational doctors, mentors, friends that I've worked with. And it is an incredibly fulfilling career path that I think everyone should try at some point, even if you're not going to stay there forever. It's a path worth following.
Well, thank you so much for talking with us today, Dr. Shannon. It has been so amazing to hear about your experiences and all the different things that you've done in your career, and especially fantastic to hear about the Royal Flying Doctor Service.
No worries. Thanks for having us on.
Amazing. Thank you so much.